We got to get to
do.
teaching. Here.
Okay, listen. This is, I am so happy that we have these two questions today, because they're going to both point to something that Ray and I have alluded to many times, and that is there are preventable cancers out here, and the questions aren't really devoted to the way they're preventable, but I'm choosing to link them together. And part of the second question we've sort of been on before. Okay, question number one. My sister is 53 years old and 10 years after node-positive breast cancer, treated by mastectomy and chemotherapy, and she has had no issues or recurrences. Now, remember, I always say you know you're cured of cancer when you die of something else.
Yes.
She recently had an abnormal pap smear. Now, remember, she's 53 years old. Mm-hmm. And a biopsy showed HPV-positive invasive cervix cancer. HPV is related to the human papilloma virus, and we're going to talk about that a great deal more in a minute. Her GYN recommended a LEEP procedure. I'll tell you what that is in just a... Well, LEEP procedure is a minor surgical procedure that just bores out the center of the cervix. And her oncologist referred her to a GYN oncologist. Now that pulls up that there are surgical oncologists that are different from medical oncologists, and so you got urological oncologists who specialize in taking out the kidney with a robot, and GYN oncologists who do big gynecologic procedures that regular GYN doctors don't do. They both recommended, what do they recommend?
A
cancer operation to remove the uterus, tubes, and ovaries. What do you think she should do, and why not the LEEP, which is a much lesser operation? And basically, what is a cancer operation versus an operation in general? Now, that's a pretty good question, don't you think?
Yes, it is, because I'm thinking the same thing. You know, what specifically makes it a cancer operation?
Well, you're going to know when I get to the end here, and you're going to know well, you know right away what I recommend, don't you? I recommend following the oncologist's advice, but I'm going to tell you why. Put up that first one. Okay, you need your glasses?
No, I can.
All right.
High-risk types of HPV are related cancer genital warts.
Now, so the first one is cervix cancer.
Right, cervical
Second
cancer.
One's head and neck cancer. We've been talking about that in the second question. But what's that one say?
Plantar's warts, common warts, flat warts, genitalia warts.
All of these warts. People, you know, how many boys you know got warts on their fingers and warts on their toes, and then how many people go to the podiatrist with plantar warts? That's the same virus that causes cervical cancer and causes 96% of head and neck cancer and 92% of cervix cancer. Pull that down now. The second thing, let's put up the next one. When we talk about the risk of breast cancer and associated gynecologic cancers, we're always talking about ovary cancer and endometrial cancer, which are related to the genetic changes. This cervix cancer's got nothing to do with her history of breast cancer. 90% of the time when we're talking about breast cancer patient with a gynecologic malignancy, it's the second cancer that comes around, ovary and endometrium, and that's why, what was her name, had her breasts and ovaries removed and her uterus removed when she was in her late 30s. Gorgeous movie star, and her name was Angelina Jolie. And she made it popular then for people with the gene to admit that they had a high incidence of cancer, and if they were through having babies, to get their uterus out. Okay, put up this next slide. This is just a worldwide map, and these colors over here tell you what the general risk is. You can pull that down now, but the general risk in the United States is much less than the general risk in undeveloped countries where they have no way to prevent or to detect cervix cancer. So this is Ray's turn now. Put up the next one. Cervical cancer
screening recommendations from United
States. Okay, we're going to focus on the United States.
Okay.
We're not going to focus on Africa and Central America and places where they have no ability to do the pap smear. Ray?
The different societies have different protocols for screening routines. American College of Surgeons has one. American College of OB-GYNs has one.
Family practice.
Family practice has one. And they are basically broken down by age group and other risk factors. Like, is it in the family? Have you had an infectious disease? Have you had a vaccination? And Bill's hitting on the very important point here is that young gals can get a vaccine against the herpes virus at a young age, and it reduces the likelihood that they will contract genital herpes.
Now, the
And
thing that
that's
he
real-
was saying right there was some of the risk factors. Number one, I mean, of course, the vaccine's a thing, but how many sex partners have you had?
And age of onset of sexual activity.
Yeah.
So,
Now, okay, so look at this now. This is just interesting. Here is one recommendation: start doing pap smears at age.
21,
This one says at age.
25.
Now, this is when to stop doing pap smears, right?
Right.
Okay, well, some of the recommendations, you can pull that down now, it's kind of confusing, but some of the recommendations stop at age 65, but we now know that most women are living to age 87, don't we?
Right.
And so we are actually picking up cervix cancer now in much older women. It used to be a disease, you'll see this in a minute, of much younger women. Okay, now I think Dr. Tidman just hit on the biggest. Put the next one up. You like these little circle things here that tell you how things are improved. What does this say right here? HPV infection targeted vaccines have decreased the amount of cervix cancer by
88%.
something that
That's
decreases
huge.
something by 88%. It's a real number, isn't it?
Yes,
Okay, well, all right. So now,
Bill, we might interject here that you're talking about screening protocols for otherwise asymptomatic healthy people.
correct.
But there are situations where you have, as when I worked in large urban centers, where you have young girls that get sexually active very young,
We're going to see that in a minute.
and they start having problems early on. So if a gal's coming in and she's 12 and she's got vaginal herpes, she's going to get a pap smear too at age 12.
Right, yeah, exactly.
So I don't want to just say that these screening activities are just for this one group. That's who we're looking at to say to
Correct. There's
to
outliers.
Joe average or lady average, this is what you get. But when you are engaged in or you're in a special risk group, pay attention that you've been identified into that group and they have special things they're going to do.
That's exactly why you need a doctor. Take a history.
Right.
Put the next one up. There are, how many is this? That must be, 30 different kinds of cervix cancer.
yes,
Virtually all of them are this top group right here.
yes.
Pull it out of there. That is what is related to the herpes virus. Now, this is a little, put the next one up. This is a little staging thing here. So this is a regular cervix. This is a normal, hadn't got any disease in it. Well, if you look at this one right here, it's got early stage, and they're talking about a LEEP procedure. A LEEP procedure goes in and just sort of like coring out the core of an apple, cores out that place like there and leaves the uterus. You can pull that down now. The purpose of that is to preserve fertility. How old is this patient? 53. What's she, 10-year survival after chemotherapy? She hadn't had a menstrual cycle in 10 years since she took her treatment, so you do not need to worry about fertility in this patient. What you need to worry about is cervix cancer and survival. So put up the next one here. We have to always have one of these for BKP. And what is that, A?
Survival.
All
curve.
right, so very early stage cervix cancer is virtually 198% curable, right? Well, let's just whip over to this one. Next one up, there's four different stage ones. Survival goes from 75% to 98%. Pull that down. So all stage ones, early cancers, aren't the 98%. It's the 98% that you want to take with the LEEP and not do some sort of bigger operation. So Ray began this discussion when he just said something about the 12-year-old girl, right? And we're talking about a 53-year-old woman, but look at this flow chart. This says management of, put it up there, cytological abnormalities.
Oh,
I'll give
okay,
you that.
yes, okay.
In patients,
Younger than 25 years.
this is a young woman's disease. Ray hit this on the head. So a young woman of 25 who became sexually active in high school can be in this issue right here, and she wants to preserve her fertility, right?
Right.
So you can see all this working through there. You can pull that down now. But this is telling you what do you do with a high-risk woman who's under 25 years old, who's got HPV in her cervix, but not a malignancy. So this tells you, there's tests you can do on the cervix when you do a pap smear, when the pap smear is normal, to tell you that there's HPV in there. We won't go into the details of that, but that's a relatively simple test. And then when you do that and you are under 25 and you do not have any cancer cells, what do? Repeat it at a year, and then repeat the HPV test at a year, and you're in another whole category, pull it down now, than those other women we were just looking at, where they said repeat. You did these, one of them said start at 21, one said start at 25, but they said repeat the pap smear. It used to be the gynecologist, when he and I were training, gynecologists would see a woman every 6 months or a year, do a pap smear every 6 months or a year. And I'm not going to say they did that because it made money for them. But once they got birth control pills, they made women come into the office at least once a year to get their prescription for birth control pills renewed, and they did a pap smear, and it ran the cost of health care up. And that's why all the Democrats want you to be able to go buy pap smears over the counter without a prescription, which I think is murder.
By birth control pills over the counter.
Yeah, birth control pills over the counter. Excuse me, what did I say?
Pap smears over the counter.
Yeah, I meant
If
birth
the pharmacist starts doing pap smears on the counter, we got problems.
No, but that's what they want, right? right now, you can buy what do you call them? Abortion pills, right?
Abortion pills.
Day after pills without
pill.
a prescription.
Yeah.
Now, if you get to let women buy birth control pills without a prescription, without their doctor having taken a history of thrombophlebitis, all the things that birth
Migraines,
control pills
all the
that's a
contraindications.
disaster. I mean, I can't imagine it, but I'll tell you, if the Faucis of the world would have that done in a heartbeat. Okay, so now we're going to talk about this patient. Put up the next one.
Management of early stage cervical cancer.
All right, so I'm not gonna make you work through too far here, but what is the clinical stage based on all that stuff we just said, and what does this say?
Radical hysterectomy with what?
Lymphadenectomy.
Lymphadenectomy.
That means take out the lymph nodes. All right, pull that down. So, in a patient, and that's over the age of 25, and that's patients who to get into that group right there, you're not trying to preserve fertility. So this group of patients either have had their tubes tied, they have decided they don't want to have any more babies, their husbands have had a vasectomy. There's lots of reasons that you can be in this don't preserve your fertility. They may not ever want any kids. They may have had 4 of them already. They may have had their tubes tied, but there's lots of things that put you in the don't preserve your fertility. If you want to preserve your fertility, you want a lesser procedure done. If you don't, you want to be able to get the cancer out and know exactly what you're dealing with. So, what's this next one say?
Types of hysterectomy.
How many are there on there?
Looks
There's
like
about
5.
10 of them. No,
Well,
there's 10 of them at least. Okay. Pull that down. Each one of these different types of hysterectomies are for different types of patients. But when you are dealing with a patient who has cancer, because we're going to go into this in much detail in the next question, you have to say to yourself, if a cancer cell gets loose from where it started and goes up to the next place it's going to go, meaning dominoes are falling over, where is it likely to go? So put that next one up. This is just a radiation port we've had out here in previous places when we've talked about cervix cancer. And you'll notice this radiation port's going all up in the pelvis and going places that are centimeters or inches away from the cervix itself. Pull that down. So here's what a cancer operation is. One of the common hysterectomies that many women that Ray and I know had in the days when they were Dr. Lyons that was up doing these procedures. If it was for endometriosis, for fibroids or something like that, it was a supracervical hysterectomy. They left the cervix in place, the entire vagina was in place, the supporting ligaments were in place, and so the sort of equipment that women are using for their sexual activity is left in place, but the fertility baby carrying part and the ovary part that can become ovarian cancer is removed. So that hysterectomy would be totally inappropriate, right, for somebody who's got cervix cancer. So the type of hysterectomy that you have to have for cervix cancer certainly is going to move the cervix. But most of the rest of these don't take into account the lymph nodes, right? That's what that said. So the difference is a surgical oncologist, GYN oncologist, is going to do a surgical procedure frequently with a robot and with a scope and all that fancy stuff. Patient might not spend the night or might spend one night, but they are going to do an operation that is much larger in scope than all of the general hysterectomies that are done to the women out here in the garden clubs for endometriosis, fibroids, and pelvic pain and everything else, because they are going to have to survey and to take samples of the lymph nodes and the areas of the pelvis where a cancer cell might have gone to grow, because you don't want to get to the laboratory and have the pathologist look at what you removed and say, oh, you got a lot of stuff, but the margins are not clear. So my recommendation, this says, what do you think she should do and why not the LEEP? The LEEP is for people who want to preserve fertility. This woman's 53 and 10 years after chemotherapy, which I guarantee you pickled her ovaries, so there's no need to preserve her fertility. And therefore, she's in an effort to make her have the highest chance of cure and put her in the top of that survival curve, the entire uterus and affected lymph nodes should be removed. And when it says what's a cancer operation versus an operation in general, that's what a cancer operation is. Now, is that a lot of education? The education is about pap smears, you need to get them, and that editorial I said both of you says that during the that was the biggest thing, along with colonoscopies and face-to-face physical exams where your blood pressure got checked, your blood sugar got checked, and your lipids got checked. That did not happen between March of 2020 and today, where people are frightened because of the COVID epidemic. And I said both of you in editorial this morning about that. I'm going to shut up and listen to Ray now.
One of the primary care take-homes from all this is that I like to explain to the youth who are coming in pretty healthy at young ages, mostly for sports physicals and initiation of care, is that our culture is sexualizing people at younger and younger ages, and there are consequences to that. And my pushback, and I'm not in any sort of religious or authoritarian concept, is that in our human development, learning how to communicate, build trusting relationships, and establish these interpersonal things is far more important than going into physical sexualization of your bodies. And while the media and the advertising and the marketing pushes the latter, the former is far more important. And the other take-home I try to get for them to understand is that this is a little bit counterintuitive. The things that tend to cause harm to us in what we call sexually transmitted diseases are wimps. Now, what do I mean that? Because how syphilis or gonorrhea or herpes or whatever are terrible sounding diseases, and when they are occurring, they're really nasty, disgusting things for people to deal with. But they are actually very wimpy bugs, if I can group them, because they require constant contact, moisture, and temperature to go from person A to person B. And that's why they are sexually transmitted. Okay? There are other things, COVID being one, and other cold viruses and pneumonia stuff, that you can get in the air or off a doorknob. These things you have to have constant, long, intimate contact. So if you don't want those things, don't be having that contact until you're ready and mature enough to do that and understand it.
Because it used to be, back in our day, that lecture right there was about pregnancy.
Yeah.
And not about disease. Now, that pregnancy part of it is also an important part of it. And what I think gets people in the South and gets people who cling to their guns, their Bibles.
Those deplorables. Yeah.
Deplorables.
Yeah.
What gets the deplorables is when the school starts teaching in the first, second, or third grade about having safe sex. It's sort of saying that
You don't have to worry about this stuff. Yeah.
but it's like wearing a bike helmet when you ride your bike or something. And I think it's absolutely criminal to take sexuality over here or a baseball helmet and a little thing. I mean, that's to protect my kid from getting hit in the head by a ball when he's 12 years old in the Little League. I mean, I want him to wear the helmet and the elbow pad, but I want him to play baseball. I don't want him to have sex using the protection that the second grade school teacher was teaching about when he was 8 years old. And that, to me, those are conflicting goals of the education system.
You're not prepared in no way whatsoever to handle any of the consequences.
Emotional consequences.
Exactly.
You start with the emotional, much less the physical.
You're not
It's
right.
the
You're not
emotional ones
right.
I'm talking about.
You're not
It's
prepared.
It's
in
the relationship.
Any way
Yeah. Now let's go
whatsoever,
back to Little
whether
League.
it's disease, pregnancy, the list goes
Well,
on.
let's get right.
You're not prepared in any way whatsoever, and they are not able to prepare you for it.
Right.
End of story.
But you're able.
Right?
Yeah. But I think a 12-year-old boy is prepared to get his tooth knocked out with a baseball.
Yeah.
He's prepared to skin his knee sliding into second base. He's prepared for the hazards of playing baseball or riding a bike or whatever it is that you've taught him other protective mechanisms for. An 18-year-old who is physically healthy is easily prepared to be a soldier and to be able to protect us.
But a 12-year-old and 13-year-old, I use that because you brought it up.
I did.
I use that. 12 years old and 13. In that area, I call it 12-year-old, okay? It's a confusing time for kids.
It's confusing when they're 16. But
Wait,
go
but
ahead.
it's
All right,
a
go ahead.
confusing time for kids, okay?
Okay.
It's called nature. All right? Get out of the way. We don't need you adults that feel you are so educated to understand that confusing time in these kids' life. Leave them alone, let them develop, and let that confusion change into who they are later on.
Let me tell you about.
How wrong am I?
Let me tell you about Tiny.
Huh?
I'm going to tell you about Tiny Williamson. Okay. Tiny Williamson. Puberty changes you. Tiny Williamson had the nickname Tiny because he must have been small. He was a basketball player that was absolutely fabulous at the E. Rivers School where I went, which ends in 7th grade. He wanted to play basketball, and he had the choice of going to North Fulton High School or North Side High School because of the area he lived in. There was only 2 city blocks in Atlanta that had that choice. The 8th grade coach at North Fulton High School, where I went, and all of our friends went, Tiny was the only one that didn't go to North Fulton, told Tiny, you're really a good player, but you're not big enough to play on our 8th grade team. And that was like the January of our 7th grade. Tiny hit puberty in February of the 7th grade, and he was 5'10" when he started 8th grade at Northside High School. He grew to 6'1". So, and he played basketball for Florida State University. But my point is that 8-month period, changed Tiny Williamson from too little to be on a team of not such a great high school to a great basketball player that ended up playing in college. And when you say you got to leave them alone because so many things are going to happen, they're going to discover girls, they're going to get pimples, they're going to grow out of their clothes if they're poor and have to get new clothes. I mean, you can't legislate that.
Did they change his name to not Tiny?
Yeah, no, he's still tiny. But that's
No, I
my
like
point.
that because I know a
Another
comparable
Tiny.
story.
All right, we got-
No, but you look at this guy and you're like, why you call him Tiny?
That's exactly right. But that he got that name when he
I
was
like
10. All right, we got to go. We got to.
Yeah, because
this,
I have made a promise to your office not to be the one